Hey guys, so just want to chat through a really interesting case I had the other day. This is a young female patient, comes in with reported left posterior knee pain, gradual onset. She'd been on a skiing trip for about a week, noticed some tightness and discomfort on the coach journey back home. This later kind of progressed into some more kind of intense pain, stiffness, and just worsening severity over time. Just going to shift you around here a little bit. There we go. Okay, so yeah, 7 out of 10 maximal severity, described as an ache, and she's saying location-wise, specifically just back of the knee, and that's not typical. That's not very common. I don't come across solely posterior knee pain a lot. Posterior thigh pain, hamstrings, those kind of things. So I'm going, okay, because the location can guide you to a greater or lesser extent with certain pathologies. So initially I'm thinking, is it something referred to posterior knee, or is it something local to the posterior knee? And then if it's something local to the posterior knee, what have we got there that is a likely kind of source of symptoms structurally? Does that tie in with things like the onset mechanism, those kind of things? So if it was, say, talk about structures that could refer into the posterior knee, I mean, we could talk about referral from more proximal structures like lumbar spine referral, those kind of things. Local to the knee, the patellofemoral joint, this is a really useful point I learned a while back, is that patellofemoral pain, yeah, a lot of times it's kind of peri-retro patella. It can be a little bit of a poorly localized one compared to, say, like your patellar tendinopathy, which is very well localized, and is also a structure that can refer to the posterior knee and kind of mislead you into assuming that it's just something, you know, local at the back of the knee itself. Baker's cyst is another one I've had with posterior knee pain. But anyway, suffice to say that we looked at aggravating activities. She would talk about stairs were painful. She didn't openly offer that. I had to sort of prompt her and investigate further. Descending was worse than ascending. Loaded knee flexion and squatting on the eccentric phase. So these all kind of make sense with patellofemoral, high patellofemoral joint reaction forces, especially into that deep squat position. Special questions, no clicking, no swelling, no giving way. She said it felt a bit unstable, and I think she was getting some of that kind of pseudo instability, that quadriceps inhibition, rather than it being like a true mechanical instability. Anyway, so when we went on to the objective, it turns out that she had some marked kind of lateral joint line pain, and I was specifically like, do you feel like that's the pain you came in? Which is like, yeah, actually, yeah, it is. She did have some tenderness and some hypertonicity through the kind of distal hamstrings, which were a bit sore. When I'm thinking about an extra-articular pathology, my three things are: does it hurt when it's stretched? Does it hurt when it's contracted? And does it hurt when I prod it and palpate it, basically? So she did have all those, but I wasn't convinced that this hamstring was her kind of primary source of symptoms. She didn't have the mechanism, she didn't have the history for really that, and yeah, it could be, you know, it's definitely not hamstring, typical hamstring strain. It could be a sort of tendinopathy, but yeah, but I wasn't entirely convinced by that. Her squat, which I used as the asterisk sign, was painful, 6 out of 10 at 70 degrees knee flexion, and was able to get a full resolution to that with a symptom modification procedure, which was my isometric hip abduction and external rotation as she went down. So she was going into some sort of knee valgus, yeah, and some internal rotation, adduction of her hip. So when we fired those up isometrically, her pain went away. She got pain on her knee range of motion, end range extension on the left was painful on passive overpressure, and then we found out she had a positive Apelles and McMurray's. So when we look at like the clinical prediction rule for meniscal tests, because this is a really useful thing when you're trying to confirm a diagnosis, you've got history of catching and locking, which no, she didn't kind of offer up, you know, without prompting as such, but then we actually found that she had clicking on the McMurray test, which is one of the other components of this clinical prediction rule. She didn't have pain with maximal knee flexion, but she did have pain with maximal knee extension into hyperextension, and she did have joint line tenderness. So she had 1, 2, 3 out of the 5, which gives you a specificity of about 90 and a positive likelihood ratio of 3.15. So that is quite a strong indicator that this was meniscal pathology. But why the hamstrings? Why would she come in with hamstring pain first and foremost? Well, if you think about part of the action of the hamstrings is that they wrap around that tibia and they're resisting in part that kind of anterior translation. She's been skiing and constantly in a kind of slightly semi-flexed knee position, a hip hinge where that tibia is sloped forwards. Now, what can happen here is that you can be in a very kind of quad dominant position without a lot of hamstring tension, and it's a vulnerable position for shear in the knee, which is basically when you think those femoral condyles start to are more inclined to slide forwards on a sloped tibial plateau compared to if you have a more vertical shin. So also, if you think about when she's descending stairs and it's worse, she's going back into that same shear vulnerable position, and I think her hamstrings are basically protectively tightening up to grab hold of a tibia. So what I wouldn't want to do is completely just release off massage all of her hamstrings and leave her potentially vulnerable to exposing her to more of that uncontrolled shear. I did release the hamstrings, I did some soft tissue to the hamstrings to reduce her symptoms and desensitize the area, but then I followed it up with the stability work and the education and the movement modifications to ensure that she was cognizant of the way she was ascending and descending the stairs and trying to avoid those shear positions for the time being anyway. That's it.